Welcome to MS Masters. Multiple sclerosis can be challenging to diagnose and to treat. The good news is there are more options than ever for your patients with MS. The challenge is an overflowing cornucopia of information that can be difficult to digest. MS Masters helps you stay on top of it all with expert presentations on key topics within MS. In this episode, Robert Bermel, MD, Director of the Mellen Center for Multiple Sclerosis at the Cleveland Clinic, provides an overview of the 10-year study data demonstrating Ocrevus treatment reduces disability in participants with MS.
Ocrevus is a monoclonal antibody that depletes B cells in the circulation. So it's a really unique administration scheme because you dose it, the drug is in the system for a number of weeks, and the effect of the medication, the depletion of the B cells, lasts 6 months or more. And so the administration frequency is once every 6 months, but the patient's not on medication that whole time, does not have to take any pills or any medication during the 6-month period after they get their infusion. So many patients find it to be very convenient. And it also has the benefit of you can't forget it. It's not like taking a pill every day where you could potentially miss doses or forget it. Once you get your dose, you know it's going to be in your system and be effective. The way we learned about B cells in MS was actually through medications like Ocrevus, because we never, for many years, thought that B cells were involved as a mechanism of disease in patients with MS. We thought MS was a T cell mediated condition. And along come medications like Ocrevus was really the first prototype in MS. And we learned that they can actually be remarkably effective. And it's almost like removing a key cog in the MS machine to remove the B cells. So that's kind of the way I explain it to patients is MS, and the immunology of MS is very complicated, but it appears as though the B cell cog is a particularly important piece of that machine. And by depleting those in the system, we can essentially halt MS disease activity. Ocrevus was approved in the US in March of 2017. We've had a lot of experience with it clinically, but obviously the clinical trials that preceded the regulatory approval started well before that. So we're lucky to have now more than 10 years worth of long-term follow-up data from those trials. The ocrelizumab open label extensions that were presented at AAN in aggregate thankfully show the impressive and encouraging long-term efficacy for this medication. After 10 years of follow-up, 3/4 of the patients who went on ocrelizumab from day one in the trials were free from confirmed disability progression by EDSS, and impressively 92% of them did not need a walking aid at 10-year follow-up. The other really consistent theme in MS that comes out strong in the ocrelizumab open label extension is that earlier treatment with effective therapy is a really important factor in success. And so we have this benefit of the early randomization of the ocrelizumab pivotal trials, where for 2 years there was one group getting ocrelizumab versus a control. In the relapsing remitting MS case, it was interferon, and in the primary progressive MS case, it was placebo. But compared to the patients that did not have the benefit of going on Ocrevus for those earlier 2 years, in other words, they were randomized to the control arms, they were more likely to incur disability progression. So, in fact, the risk of having disability progression measured by EDSS was basically cut by 1/4 if you measure it by EDSS progression. And the risk of needing a walking aid was essentially cut in half if you went on ocrelizumab those 2 years earlier. We see this consistently throughout other MS treatments, but I think it comes out even stronger when you have a highly effective therapy like ocrelizumab, where those 2 years really matter. It makes a big difference. And so patients ask me, how soon should I get started on this medication? It's not a 911 emergency. Like, you don't need to get started on it tomorrow after we diagnose you, but we do measure like in months and definitely years. Earlier treatment is definitely better. These phenotypes of multiple sclerosis, relapsing remitting MS, primary progressive MS, they're sort of artificial distinctions. We name them this way based on how the patients tend to progress over time in our clinics and the aspects of their disease phenotype that we see. But they're sort of artificial distinctions. Relapsing remitting MS has now become the most treatable type of MS. It's the kind that all of the medications, including ocrelizumab, are approved to treat. These medications do an excellent job of suppressing relapses and suppressing new inflammatory disease activity. And when I say that, I mean new relapses that are clinically evident or new MRI lesions. A medication like ocrelizumab is extremely good at doing that in relapsing remitting MS, and so we've tightened our tolerances. If we see one new T2 lesion on an MRI scan in a patient on disease-modifying therapy, that's too much for us now, because we can afford to have these really tight tolerances and control the disease very tightly from the get-go. In primary progressive MS, it's been much more of a challenge to slow down progression, and that's what we're talking about. Unfortunately, we often don't have the tools to completely halt progression once it's started. In primary progressive MS especially, we focus on controlling the aspects of the disease that we can, acknowledging that even if a B-cell depleter like ocrelizumab doesn't address every single mechanism of disease and may not address aspects of, for instance, innate immunity response or CNS compartmentalized inflammation, it does address peripheral immune response, and it does address issues of active inflammation. We end up starting a medication like ocrelizumab and monitoring patients very, very closely in primary progressive MS. Ocrelizumab is still the only medication that's approved to treat primary progressive MS in the US, and we use it in that patient population for sure. Patients, when we sit down in an exam room and talk about medication, and we're talking about chronic disease, MS, they will often ask, what are we expecting the medication to do? How will we know if it's working? And what are the side effects? And I tend to break side effects up into side effects, meaning am I going to feel differently, and complications, health complications. The safety aspects of ocrelizumab are another aspect that's been described in the 10-year follow-up. One of the things that we watch as treating neurologists is the immunoglobulin levels. You could picture a person with MS being on therapy for 1, 2, 5, 10, 15 years, in a long period of time, because MS is a chronic disease and people get it when they're young. They're contemplating being on this medication a long time. They often want, safety data in a long-term experience. So having a 10-year follow-up with safety data that, in the case of these data that are presented, show that the immunoglobulin levels really remain stable as a group over time and do not decline as time goes on, is very reassuring for patients. So not only can we tell them that the medication is going to help them and be safe in year 1 or in year 2, but it looks like the efficacy and the safety of this medication persist out to 10 years. And I think that's just, really comforting for patients. We watch for things like infections, and patients with MS do tend to get infections, especially if they have a bladder that doesn't work as well, or they could be more susceptible to upper respiratory infections. And so it always becomes a challenge teasing out which infections would have happened to anyone in the course of their normal life, even if they didn't have MS. I could get an upper respiratory tract infection. Many people do in the winter. Teasing that out from medication-related infections. And so we do a lot of looking at, are the rates of infections higher than we would expect them to be? And are the immunoglobulin levels any lower? Because immunoglobulins are immune proteins, and we want to know, is it because of a low immunoglobulin level that people are having more infections? And it looks like there's no relationship to those things at all. It looks like longer-term treatment with ocrelizumab does not necessarily increase the risk of infection in patients with MS. The other aspect of safety that patients and prescribers are attuned to is the risk of malignancies. Whenever we affect the immune system for a long term, we always worry that patients might have a reduced policing of invaders in the body, and that they could have potentially an increased risk of malignancy. So that's another thing that's monitored for closely in the open label extension trials. And compared to background rate of malignancies, using epidemiologic data that's available from different demographic and geographic groups, so we can actually compare to different nationalities and different registries. Reassuring also is the fact that it does not appear that there's an increased risk of malignancy with long-term treatment with ocrelizumab. B-cell therapies have become the go-to medication for patients with MS. And we've seen evidence now that they're effective in the long term. If you start them 2 years earlier, it actually portends even better long-term outcomes. These are all good things. But I think there is still a need to get these treatments to more people, more patients out there. Not everybody can access an infusion center to get an infusion with ocrelizumab. Not everybody has access to a subspecialty neurologist that feels comfortable prescribing high efficacy therapies. And we're also seeing some data from a study called CHIMES, specifically looking at African Americans and Hispanic individuals with MS, communities that are historically under-resourced in terms of medical care, also could potentially benefit from increased access to medications like ocrelizumab. Getting the medication out to populations that were not the first to get access to it will be this next stage of our treatment era with ocrelizumab.
Thank you to Dr. Bermel for sharing his knowledge with our listeners in this episode of MS Masters. And thanks to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the field of neurology. MS Masters is brought to you by the editors of Practical Neurology.